Great, so good afternoon, ladies and gentlemen. I'm delighted to present to you today. I'm based in the Rotunda Hospital and have done this work under Professor Fifelkafat. So, as we know, there's significant developmental differences in left ventricular myofiber architecture between term and extremely preterm babies. However, the postnatal adaptation of myocardial function between preterm and term infants over the first week of age warrants further study. So, as we're all aware, the cardiac physiology of premature babies is quite different to that of term infants. For example, premature babies have impaired diastolic function, which results in abnormal relaxation and ventricular filling during diastole, which again can be impacted upon by a fast heart rate or invasive ventilation. And we know that the neonatal myocardium is also poorly tolerant of increased afterload as compared to older children. So the left ventricles have unique helical arrangements of their subendocardial fibres, which are orientated in a left-handed fashion, and their subepicardial fibres, which are orientated in a right-handed fashion. And because of these different orientations, the left ventricle can have unique rotational properties. So the base of our hearts is at the level of the mitral valve, and the base actually rotates in a clockwise fashion. The apex of our heart, which is obviously at the bottom of the heart, rotates in an anti-clockwise fashion. And when these are working in synchrony, it's actually creating a ringing motion, which can help support ejection of blood from the ventricle. So left ventricular twist is the net effect of the basal clockwise rotation and the apical anti-clockwise rotation. And as I said, this creates a ringing motion to help support systolic and diastolic function in the left ventricle. So this is a short axis parasternal view at the level of the mitral valve. So this is the base of the heart. And utilising speckle tracking echocardiography, we can determine the degree of basal rotation, and the base is moving in a clockwise fashion. It's denoted as a negative deflection. And then at the apex of the left ventricle, this is moving in an anti-clockwise fashion, which can be detected again by speckle tracking echocardiography. And we can determine the degree of anti-clockwise rotation of the apex. And that's denoted as a positive deflection. So the net effect of the clockwise basal rotation and the anti-clockwise apical rotation is your left ventricular twist. So what speckle tracking echo actually does is divide the left ventricle into 6 segments that are denoted in different colours. And at both the base and the apex, it will determine the degree of rotation in each of those 6 segments. So you can see the colours here. And then what it does is it plots the base as a negative deflection, and each of the 6 segments is represented by a particular colour. And then the net effect, the net result, the average of the 6 segments is denoted as the dotted line there. So the base is denoted as a negative deflection. The apex, which is moving in an anti-clockwise direction, again, the software tracks each individual segment, averages that, so that's the dotted line there, and that is your apical positive rotation. So what it does then is it plots the average lines, which were the dotted lines in the previous diagram. So you can see your positive apical deflection, your negative basal deflection, and then the difference between these is our twist. And then it will also tell us the rate at which that twist and untwist is occurring at. So this is how quick the left ventricle is twisting in systole, and then it will also tell you how quick it is untwisting in diastole. So you can get left ventricular twist rate and left ventricular untwist rate measurements also. So why do hearts twist at all? So in systole, the ringing motion of the left ventricle twists. It supports ejection of blood during systole, but it also has impacts on the diastolic function of the heart. So as the LV untwists to return to its baseline, undeformed, untwisted shape, this actually helps augment early diastolic filling. So it actually helps to create a negative pressure gradient. It's like a suction action that helps promote early diastolic filling, and it may actually be an adaptive response in cases of reduced LV elasticity. So as we know, premature babies, their hearts are stiffer, they've less collagen, so this might actually be an adaptive process for them to help their diastolic filling as well as their systolic function. So this is what we're thinking, is that twist is a compensatory mechanism for myocardial stiffness. And as I said, premature babies have a stiff myocardium due to a lack of collagen. But the differences in LV twist and untwist between term and preterm babies has not been previously studied. There is some research regarding using adults and rotational mechanics looking at different disease states. So there are papers documenting impaired LV function in patients with acute MI and heart failure. Adult studies have also looked at left and right ventricular rotational interdependence, and it's actually starting to be used now as kind of a measure of a therapeutic intervention. For example, measurements of improvement in LV twist following a surgical intervention. In the neonatal realm, a few studies that we've done so far, we've demonstrated a lack of basal rotation in babies with Down syndrome compared to infants without Down syndrome, and babies with HIE have been shown to have lower left ventricular twist and untwist rates when compared with healthy controls. So the hypothesis of our current study was that rotational mechanics in healthy term babies are going to be different to those of extremely premature babies. So the aim of our study was to compare left ventricular rotational mechanics between term and preterm babies over the first week of age. So we compared a historical cohort of extremely premature babies less than 29 weeks gestation against a prospectively recruited group of healthy term babies. An echo was carried out on day 1, 2 and 3, and we measured basal and apical rotation, LV torsion. So torsion is twist indexed to LV length, and the reason we use torsion is because it allows comparison across different heart sizes, so it standardizes it. And then we looked at LV twist and untwist rate, and then obviously compared the measurements between the two groups over the first week of age. So in our term cohort, we had 30 babies. Their median gestation was 39 weeks. Their median birth weight was 3.6 kilograms, and our premature group were 51 babies with a median gestation of 26 weeks and a median birth weight of 1 kilogram. So to go through this slide, so term babies are denoted in blue, premature babies are denoted in red. An asterisk means that there was a statistically significant difference between premature babies and term babies at that time point, and then a cross means that there was a statistically significant difference within the group over the first week of age. So looking at the term babies, you can see that there was no difference over the first week of age in either their basal or their apical rotation. And just to remind you that the base is at the mitral valve, the apex is at the bottom of the heart, the base is moving in a clockwise direction, denoted as a negative deflection, the apex is moving in an anti-clockwise direction, denoted as a positive deflection. So there's no difference in the rotational mechanics of the term babies. However, when you look at the preterm babies, you can see that there's both a statistically significant difference between the prems and the terms on day 1 and across the premature group over the first week of age. So what's happening is that at the start of the week, their bases are actually moving in a anti-clockwise direction, denoted as a positive value, and then by the end of the week, their hearts are moving in a clockwise fashion, denoted as a negative value. So what we think is happening is that at the start of the week, their bases are actually being pulled by the apex into an anti-clockwise direction, and then as it starts to kick in over the week, they're rotating in a clockwise fashion, and that ringing motion is starting to kick in over the first week of age. What we also see is that over the first week of age, the premature babies, their torsion measurements increase significantly. And to remind you, LV torsion is twist indexed to LV length. So this increase in torsion of the premature babies over the first week of age, that's driven by the changes in the basal rotation. And what you also see is that over the first week of age, the untwist rate in the premature babies is also significantly increasing. So they're trying to compensate. They're trying to help their systolic and diastolic function, and that's why those mechanisms are kicking in. So in summary, in the term babies, we see that there's no change in either the basal or the apical rotation. There's a lack of torsion over the first week of age, and their untwist doesn't change. However, in the prem babies, although there's no change in their apical rotation, their basal rotation does become more negative. It starts to move in a clockwise fashion, and then this is driving a significant increase in their torsion over the first week of age and a significant increase in their untwist rate. What's interesting is that when you look at adult studies, so in individuals over 65 years of age, they are also having increased basal rotation. Again, because as you age, your heart will become more fibrotic, you'll have more diastolic dysfunction. So we're seeing that kind of compensatory mechanism is kicking in older adults. So, in conclusion, we feel that augmentation of torsion and untwist rate in premature babies is likely to represent a compensatory mechanism and an adaptive response to compromised longitudinal systolic and diastolic function in premature babies. And so going forward, what kind of clinical relevance might this have? So we'll need to figure out, can left ventricular rotational mechanics be used to assess the degree of diastolic dysfunction in prems and predict short-term outcomes? Can we use these measures to be a marker of disease severity and to monitor response to therapeutic interventions? And can LV rotational mechanics be used as an early predictor of later myocardial performance in adulthood? So, as I'm sure you know, there's studies coming out now that are showing kind of higher rates of heart failure, etc., and myocardial dysfunction in babies who are born quite prematurely. So potentially could some of these markers be something that we can use to help predict what patients might be at an increased risk? So a lot of this is brand new, but there's definitely fertile ground for further studies and lots more to learn. So thank you very much for your attention.